I am Dr. Stephen Liu, the Director of Thoracic Oncology at MedStar Georgetown University Hospital. I treat patients with cancers of the lung, all different stages, and it's all different types of people. There are some patients that have a heavy history of smoking, some who have never smoked at all, some who present with symptoms from the lungs, breathing, coughing, some who have no symptoms where their cancer was picked up incidentally or on a screening scan or a chest x-ray they had as part of their physical. Lung cancer can affect anyone. As we say, the only thing you need to have lung cancer is lungs. So my role as an oncologist is not to make the cancer smaller. It's not to try to keep the cancer under control. It's to make the lives of my patients better and hopefully longer. And we do that with different ways, but my job is not to see how much chemotherapy I can deliver to someone. It's really to try to improve the quality and quantity of their life. I think in oncology, what struck me early in my training were the intense relationships that we have with our patients. When someone gets a diagnosis of cancer, it's a very emotional journey. It's a very lonely one, even for patients with a lot of support. And to be in that role, guiding someone through that, I think really is a privilege, and it's something I take very seriously. When I look at lung cancer specifically, what struck me was how poor the outcomes were and how little progress had been made when I first started my training. And in the past few years, we've made remarkable progress, but the outcomes are still nowhere near where they should be. When I look at lung cancer as a field and the research and the clinical investigations we're doing, it's because there's so much room for improvement. It's because it's an area where we can make so much of an impact. I think for the first time in decades, we have exciting drugs that really work. And part of it has to do with understanding that lung cancer is not one disease. I think we're all comfortable with recognizing lung cancer and breast cancer are different. But we're starting to realize that within lung cancer, there are dozens of different types of cancers. True, they happen to be in the lungs, but biologically, they're behaving differently. And if we have the ability to recognize that, well, then we can tailor our treatment effectively. We're taking some of the guesswork out of treating lung cancer and really refining our treatment, delivering it where it's most likely to work. And that's where we've seen remarkable progress in the past couple of years. When I wake up and go to work, I know that I'm going to have a positive impact on the lives of my patients. When I see a patient, I know that I will be able to help them in some way. And whether it's discussing a new exciting treatment, whether it's referring to surgery, reviewing a CT scan, whether it's comforting them, alleviating symptoms, I know that every patient I interact with, I will have a positive impact. And there's nothing that's more motivating to get out of bed in the morning than that. At MedStar Georgetown University Hospital, we have a team of dedicated specialists with access to the latest technology to provide the highest quality care in light of the most recent advances for lung cancer. You see, all I do is treat lung cancer, and so I know the disease very well in and out the latest advances. And we have surgeons, pulmonologists, radiation oncologists, all working together as a team to ensure that our patients have the best chance going forward. So cancer is a family of diseases of abnormal growth, where parts of our body are no longer bound by the normal rules that maintain order in the body. So processes like growth and survival, migration, these are normal for our body. We need these to survive, to be healthy, but they are controlled. These processes are turned on and turned off. And if the cell is damaged and stays in the on position, if it starts breaking those rules, uncontrolled growth, that's cancer. The cancer that starts in the lung is a lung cancer. And that's an important distinction. Many cancers can spread to the lungs, but a cancer behaves and is categorized by where it started. We know a lot about lung cancer. We don't totally understand why it happens in some people and not others. Smoking remains a major risk factor for the development of lung cancer, but many lung cancers are not smoking related. In fact, if you look at adenocarcinoma of the lung, that's the most common type of lung cancer, a woman diagnosed in America today, 1 in 5 will have never smoked, and many more will have a cancer that isn't the result of their smoking. We don't know why those cancers happen, but we know these cancers are different. We're still in the process of figuring out why cancers develop, but certainly it's no one's fault. No one does anything to get lung cancer. It's a process we don't totally understand, but we're getting closer. We think that there are some types of lung cancer where you can inherit a risk to develop them, but those are fairly rare. Most lung cancer is not the result of things we inherit from our parents or pass on to our children. It's the result of things we're exposed to during our adult life. The treatment for lung cancer really depends on the stage. And in broad terms, for an early stage lung cancer, we'll often rely on surgery. For a cancer that's maybe involving lymph nodes or structures nearby, we may rely on radiation and chemotherapy. For a cancer that's more advanced, we need medicines, targeted agents, often pills, immunotherapy, chemotherapy. More and more, though, we're seeing that we need more than one type of treatment to effectively treat a lung cancer. And that's why we need multiple different specialists, each bringing their own expertise to deliver the type of treatment that's needed at that time. So at MedStar Georgetown, we rely on a multidisciplinary team to treat everyone with lung cancer. Lung cancer cannot be treated by one specialty. No lung cancer specialist is an island. We need help from our colleagues that bring different experience and different expertise, as well as different tools to really treat that lung cancer effectively. For example, an early stage lung cancer may be treated with surgery alone. And in the past, that may have been the only treatment we needed, but we now know that many of those cancers find ways to come back. That even at the time of surgery, even if we don't see cancer on the best quality scans, many times there's microscopic cancer still there that we can't see. And so we may rely on things like radiation therapy, like chemotherapy, targeted therapy, even immunotherapy. And these can help make the surgery more effective. In some cases, given before surgery, it can even make the surgery less complicated and smoother. For other cases that are advanced, where historically we might have relied on chemotherapy, we now know we have newer drugs, better drugs, targeted agents given in a rational way, immunotherapy drugs that can evoke an immune response against the cancer. And in those cases, with an advanced lung cancer, we might not historically have thought about radiation or surgery. But we're learning more and more to not take anything off the table. And even for someone with a stage 4 cancer, there may be cases where surgery is appropriate, where radiation is appropriate. The field is constantly moving. It's moving very quickly. And so we really need a team of experts to constantly plan our treatment, reassess what's going on now, and adapt it to make sure we get the best possible outcomes. When we talk about the degree of specialization that we have at MedStar Georgetown, it's not just a matter of the physicians like myself, it's a matter of the equipment and the tools. We don't have a one-size-fits-all surgery suite or a procedure suite. When we look at our pulmonologists, we have bronchoscopy, electromagnetic navigation, robotic bronchoscopy, different tools for different circumstances. Our surgeons are highly skilled at minimally invasive, thoracoscopic, robotic surgeries. Our radiation oncologists have more than traditional radiation therapy. We have proton beam, cyberknife, pencil beam, many different types of tools. Our pathologists have access to the latest genetic testing, molecular analyses. Couple that with the experience of focusing on one disease, and we really have a team of specialists that's able to provide the latest and greatest care for anyone diagnosed with any stage of lung cancer. Immunotherapy is an exciting new type of treatment where we deliver medicines to treat a patient's immune system so their immune system attacks the cancer. Our immune system is actually a very powerful defense against cancer, and many early cancer cells are eliminated before they come to the surface by our immune system. Cancers that I see in my clinic are cancers that have figured out some way to escape from our immune system. Immunotherapy restores our immune system's ability to identify and eliminate those cancers, to restore that balance. And immune-mediated responses, our immune system attacking that cancer, that is very different from a chemotherapy response because it can last, it can be durable, and there's really no limit as to how long immunotherapy can work for. This is probably the most important advance that we've had in recent years, and it is essential for anyone with lung cancer to see if they're a candidate for immunotherapy. So we use immunotherapy to try to restore our immune system's ability to identify and destroy lung cancer cells. Most commonly, cancers will express a certain protein on their outside, and that protein on the cell surface will allow them to escape our immune system, prevent our immune system from activating itself, from mobilizing other white blood cells or lymphocytes from attacking the cancer. If cancers can prevent that activation, they can survive, and we call that immune tolerance. The medicines we use try to take away that defense. And so now our cancers are recognized by our immune system and successfully destroyed. This has primarily been used in stage 4 lung cancer or late stage lung cancer. But we're seeing now in recent advances that in earlier stages of lung cancer, where outcomes are still quite poor with standard treatment, delivery of immunotherapy to stage 3, stage 2, even around the time of surgery can be a very effective type of treatment. To determine if a patient is a candidate for immunotherapy, or maybe better put, to determine whether immunotherapy is likely to work for a given patient, we need a combination of genetic testing of the cancer and an analysis of the proteins on the surface of those cancer cells. That's analysis that can be done at commercial laboratories or done in-house in certain pathology labs, including MedStar Georgetown University Hospital, through testing biopsy specimens, tissue specimens, even patient blood samples. We can identify specific vulnerabilities that tell us, is this cancer likely to respond to immunotherapy, or is there a different, better type of treatment out there? In its current form, immunotherapy is delivered intravenously. And so an IV goes into the arm, and the medicines are given over the course of about an hour or so. There are different types of immunotherapy. Some are given every 2 weeks. Some are given once every 6 weeks. Consistently, immunotherapy is better tolerated than chemotherapy, and in the right setting, much more effective. It doesn't have the side effects of historic chemotherapy. We don't expect hair loss. We don't expect patients to feel ill. It requires close monitoring and an experienced team, but it really is a safe and effective type of treatment that's implemented on a daily basis at MedStar Georgetown. Well, immunotherapy doesn't work for everyone, and lung cancer is not a disease where we can make promises or guarantees. But if immunotherapy does work, it has the potential to keep working. We can induce T-cell memory, and our immune system can continue to attack that cancer, prevent it from recurring even long after we stop that treatment. There are patients that have been receiving immunotherapy for many years without their cancer coming back, patients who have stopped all treatment and their cancer never returns. That's not everybody, but it's more people than it was. And with newer treatments, with better types of immunotherapy, it's going to be even more people. So how does immunotherapy affect our prognosis? There's no limit as to how well these drugs can work. If you ask me today, what type of treatment do I have that can still be working 10 years from now, it's immunotherapy. Targeted therapy refers to a class of medicines that's delivered to very specific subtypes of lung cancer. We know that there are many different types of lung cancer, and if we look at the DNA level, we can identify what mutations brought about that cancer. Now, that will tell us a bit about the biology of the cancer, what's making it grow, what's making it thrive. And while the cancer would view those changes as a strength, we view it as a vulnerability, a way to attack that cancer. Because if the cancer is relying on a certain protein to survive, what happens if we take that protein away? We've developed new medicines, and really this is a field of medicinal chemistry, where rationally designed medicines can target very specific changes at a cancer. And if we identify what those specific changes are, we have drugs that are very likely to work. Decades ago, when we would give chemotherapy, it's a setting where we would hope that it would work, but know that often it wouldn't. For targeted therapy, because we've planned, because we've identified a vulnerability and are delivering a specific medicine to a specific patient, it's not a question of hoping that a drug works. It's really a situation where we expect it to work, where we have confidence that this is the right medicine right now. And it's that confidence that really makes targeted therapy a welcome advance for the treatment of lung cancer. Targeted therapy are medicines that are very likely to work. They'll work for almost everyone. And because they're focused on unique changes within the cancer, they generally have very few side effects. If we're targeting a protein that's unique to the cancer, that's selecting for the cancer, it'll often leave normal cells alone, which is very different from historic treatments of chemotherapy, radiation treatment. If we can hone in and really focus our efforts on what's wrong, we can deliver effective treatments that are well tolerated, that you can take every day. And I promise you, there are people that you interact with on a daily basis that are taking these targeted drugs, and you have no idea. Really taking the clinic, taking that sense of being a patient away and allowing patients to really live with this cancer as opposed to dying from it. So the key to targeted therapy is proper testing. We have targeted pills that are available on our shelf where if we give them to the right person, they will almost certainly work. But if we give them to the wrong person, they will have a 0% chance of working. And so precision is key. And it's a matter of testing the tumor and sometimes testing the patient in their blood. That testing can come in many different forms. We have the ability to do that testing right at MedStar Georgetown University Hospital. We partner with some other companies that have the latest in technology to make sure we provide accurate and timely genetic testing to really identify what those vulnerabilities are and plan that treatment appropriately. Chemotherapy we use now is much better tolerated, fewer side effects. Often patients will never have vomiting, patients won't lose their hair. They have different types of chemotherapy now than we did before. And we still use radiation therapy for the treatment of lung cancer, but the radiation we're using now is very different, much more focused, pinpoint. And our radiation oncologists have access to the latest advances, to newer forms of modulated radiation therapy, proton beam radiation therapy, pencil beam radiation therapy, cyberknife, stereotactic radiation surgery, different tools for different circumstances, and the experience you need to really implement them at the right time. Now, chemotherapy and radiation are not appropriate for everyone. For certain types of cancer, it is an important type of treatment because it does offer the ability to, for some people, really cure that cancer. But we're delivering them in different ways. And when I think of chemotherapy and radiation, those are probably the toughest treatments that, as a lung cancer doctor, I'll ever have to deliver. But we have the experience to deliver them safely and the judgment to know when we need that type of treatment. While we appreciate that smoking does have a link with certain types of lung cancer, it's not responsible for many cases of lung cancer today. And it's important we dissolve that link because when someone has a certain constellation of symptoms, it's important to consider a diagnosis of lung cancer even if they've never smoked. A large fraction of my patients have never smoked, never drank, exercised, do everything right. Cancer doesn't care. It comes to people at their best, at their strongest, and it's not necessarily related to smoking. What we're seeing over the past 10 years is really a rise in lung cancer in non-smokers. We're not totally sure why, but we have researchers at Georgetown that are trying to figure out why that happens and how to best treat those cancers. We do know that those cancers are different, that smoking-related cancers and non-smoking-related cancers often are fundamentally different. They have different vulnerabilities, different biologies, and increasingly are being treated differently. Well, EGFR stands for epidermal growth factor receptor, and this is a certain gene, a part of our DNA, that when turned on tells our cells to grow, to survive. It is also an oncogene. meaning if we damage the DNA in a certain way, if we change that DNA, if we introduce a mutation in that DNA for unclear reasons, then those cells will always be on. And that's when a normal lung cell turns into a lung cancer. But if it's relying on EGFR to grow, to survive, there are now classes of medicines that will turn off that EGFR protein. If someone has a specific type of EGFR mutation, these medicines, often pills, will almost always work. They will work very quickly, work for a very long time. However, we're learning more and more that there are a lot of details we have to account for, and not all EGFR mutations are equal. Some will predict response to these pills right away, but for some of these mutations, we really need a different type of therapy. And so the details matter. We really need specific types of mutations to know what is the right treatment for a certain patient. In years past, we suspected EGFR mutant lung cancer in someone who was a bit younger, someone who had never smoked, who had adenocarcinoma of the lung, maybe was of Asian descent. But increasingly, we're seeing these types of lung cancer in everyone. Now, smoking doesn't protect you from developing this type of lung cancer. And so I see these mutations in patients who have smoked, in men, young, old, all races and creeds. And really, it's important to identify what those mutations are, no matter what the patient looks like in front of us. We need to understand the identity of that cancer if we're going to treat it properly. So EGFR mutations are diagnosed from testing the DNA of the cancer. A cancer is diagnosed from a biopsy, but once we identify a lung cancer, genetic testing of the tumor can identify EGFR mutations. That can be done from biopsy specimens, from surgical specimens, or even from blood samples. EGFR lung cancer is treated typically with EGFR-directed medicines. Now, for someone with a stage 4 EGFR mutant lung cancer, we'll often use oral targeted therapies. When taken once daily, with pretty minimal side effects, those drugs are very effective and tend to work for a very long period of time. However, there are other EGFR mutations that will not respond well to those medicines, where we need to employ different medicines, newer medicines. We're also seeing advantages to using those targeted drugs in even earlier stages of lung cancer, in patients who have had radiation, patients who have had surgery, maybe patients that are going to surgery. And so we're implementing these tools all through the course of advanced lung cancer. Lung cancers that have these specific genetic changes that can be treated with targeted therapy generally have a much better prognosis, but only if we deliver that targeted therapy. If someone has a mutation or a fusion, some vulnerability that we don't identify and that we don't take advantage of, we forfeit that advantage. And so it's not enough to just have that vulnerability. We need to recognize it and to act upon it. At MedStar Georgetown, my team and I always want to deliver the best possible treatment today, but we really have our eye on the future and developing the next class of medicines. We've been fortunate enough to be involved in many of the latest drug developments and a lot of the recent FDA approvals. We're always looking for what's next, what's better. If we had a disease where our cure rates were 99%, we might be satisfied with what's out there. But that's not the case in lung cancer, where our standard treatment, the treatment we've been using for years, isn't good enough. We want something better, and that's where clinical trials come in, where we're developing newer medicines, newer targeted drugs, identifying new targets where we don't yet have approved drugs. And when we look at classes of treatment like immunotherapy, a potentially transformative type of therapy, we want to get better at delivering it. We want that long-term benefit for more people, for everyone. That really is the goal of the MedStar Georgetown Thoracic Oncology program, to deliver long-term meaningful benefit for everyone with lung cancer. Clinical trials are an important part of cancer care. In the past, it might have been considered a last resort when there really wasn't anything else out there. But as we're getting better at designing these drugs, at anticipating what is likely to work, what are the vulnerabilities of a cancer that we need to leverage, in many cases, a clinical trial may be the best first treatment. Decision to join a clinical trial is something that needs to happen after a discussion with a patient's oncologist. It is a community of academic oncologists, and we know exactly what is out there, what trials are best for certain patients. But it all starts with testing, with identifying what those cancers' vulnerabilities are, so we can direct patients to the right treatment and to the right clinical trials. When a patient enrolls in a clinical trial, it's very important they understand what's involved. We're getting access to a drug, in some cases, years before it's publicly available. Drugs that, in many cases, we know can be very effective. When I look at currently used immunotherapy, targeted drugs, the most exciting agents, new on the market, these are drugs that are not new to us. These are drugs that we've been using in clinical trials for 8 or 9 years. It just takes a long time for them to reach the market. A clinical trial gives us early access to what is sort of the next best treatment. But in exchange, it does require a lot from the patient. While the trials don't charge for these new medicines, and the medicines are provided by the study, there is still a cost to the trial. The cost is time. With a new medicine, we want to be sure that it's safe. And so when a patient receives a medicine, we have to watch more closely. There are more frequent visits, phone calls, televisits. There are extra blood tests to see what effect the treatment is having on the patient and what effect the patient's body is having on the drug. We need to learn these things so that when we figure out why this drug works so well in some people, how it works, why it doesn't work in others, that we can more effectively deliver it for the next generation of patients with this cancer. And so the benefit is to the patient in getting this new drug, but also to the next generation of patients with this cancer so they can have a better therapy and so on. I can't stress how important the molecular biomarker testing is for patients with non-small cell lung cancer. When we run these tests and identify specific vulnerabilities, it sends us down a completely different path. And sometimes that testing takes a little time, but I'm not looking for the fastest treatment. I'm looking for the right treatment. And it's really my responsibility, my commitment to be sure we get it right the first time. When we have a vulnerability identified in a lung cancer that matches one of these newer targeted drugs, whether it's something that's FDA approved or something that's only available through a clinical trial, these drugs are very likely to work right away, to work very well, few side effects, and in many cases to work for many years. But if we deliver that treatment to someone without the right mutation, it won't work. Not only do we use these vulnerabilities to select targeted therapy, we use them to deselect immunotherapy, and that's critical. Immunotherapy is very exciting, and we're very strong advocates for the use of immunotherapy. But in someone whose cancer has one of these vulnerabilities, immunotherapy will not work. Our understanding of cancer and cancer biology is moving forward at breakneck speed, and it is really difficult to keep up. At MedStar Georgetown, we're focused not just on how we used to treat it or how we're treating it today, but really focused on developing the next great ways to treat cancer, not just lung cancer, but all cancers. Part of getting treatment at an NCI-designated comprehensive cancer center is really involvement in that next wave of advances. From a basic science level, where we're partnering with university researchers, from a multidisciplinary approach, where our surgeons, our radiation oncologists, our pathologists have access to the latest technology, the highest fields. It's really a matter of standards, making sure that everyone is receiving the best possible care and having access to what is even better. One of the philosophies we also have at MedStar Georgetown is really taking care of the entire patient as a whole. And so it's not just a matter of selecting what is the best possible cancer treatment, at this moment in time, it's really paying attention to all the other needs. I work very closely with our nutritionist, who's focused specifically on patients that are undergoing cancer treatment, with our social workers and our case managers, with our psychologists and our psychiatrists, really all of that supportive care, because cancer doesn't just affect one patient, it really affects everyone around them. And it's important we provide that support to make sure patients can get back to the things that are important, to their normal life outside these walls. I think lung cancer care has to be delivered by an experienced, specialized team. Oncology has gotten so complex. Advances occur on a daily basis, and it is impossible to keep up. It's that degree of specialty that really is critical to the best care.